If you're good, then.
Yeah. You can kind of start your spiel.
All right, perfect. Thanks, Churchy. All right, good morning, everybody out there in internet world, as well as you guys that are sitting. The advantage of being an advanced EMT in this county is that you get to do a lot of stuff. The disadvantage of being the youngest, or maybe not the youngest, but at least one of the newest advanced EMTs, you get to teach things like gynecology. But we're going to have fun. We're going to get through it. Gynecological emergencies are something that we don't deal with very often, but they do happen. And it doesn't matter what gender you are, you're going to have to deal with them. Let me get back on screen. Did you click me? Yep. Thank you. All right. Not going to worry about that. Not going to worry about that. Probably one of the largest issues that you're going to have is vaginal bleeding, and that's what you're going to get called for. And it's interesting that, you know, it's not the young 30-year-old usually that suffers from these types of problems. A lot of times we'll get like 70-year-olds, 80-year-olds suffering from vaginal bleeding, and it's still something that we have to deal with. So we're going to talk about that. We're going to talk about SA, or sexual assault. We're also going to talk about infections of the female reproductive system. It should tell you something that there is an entire separate branch of medicine devoted strictly to gynecology, not even just obstetrics, but gynecology itself. The female reproductive system can have a lot of stuff that goes wrong with it. Girls and women in their childbearing years are generally the ones that have gynecological problems, okay? And we'll deal with that, things that, like your slide shows you here, where you're dealing with excessive bleeding. They can have soft tissue injuries from like a sexual assault, where, for example, maybe you've got you've had a rape and the soft tissues have been damaged. STDs, common. Actually more common than you might think. For you younger guys, be careful out there. And then vaginal discharges, a lot of times that are associated with gynecological problems. It may be a purulent discharge, maybe I mean, it's normal for the vagina to have a standard discharge to it. But if that changes to an odoriferous or purulent discharge, changes color, most of the time she's probably looking down and going, maybe I ought to get this checked. Yeah, that's one of the things. If she tells you that, then you might have something that you have to deal with. Your basic anatomy, physiology. What we've got, female reproductive system on your slide. You can see you've got the ovaries, the fallopian tubes, the uterus. Cervix then is the opening from the womb or the uterus into the vagina. And then you've got the vaginal canal, all right? The ovaries produce ova. That's where they get their name. The secondary oocyte is the egg that is released from the ovary and then transfers itself through they're almost like little fingers. The ovaries are not actually attached to the fallopian tubes. That once that oocyte or that ova is released, then it is captured by the upper end of the fallopian tube, and then transfers itself down the tube into, what's that? Sorry. No problem. Transfers itself into the womb. So then the fallopian tubes themselves extend from the uterus. They terminate near the ovary, again, on each side. They're not attached. And then from there, looking at that again, you've got the uterus. The uterus is actually a muscle, okay? It is a muscular organ. When we talk about, or when you hear a woman complain of menstrual cramps, for example, they're muscle cramps. That's what they are. That's why they hurt so bad. When you think about getting a Charlie horse in your thigh or in your back, and you're like, oh my God, this thing's killing me, all right? That's why, you probably shouldn't feel, or you should at least feel badly sometimes for the ladies in your life when they say, I've got cramps this month, because that's what they're dealing with. Same type of thing. It's just theirs is inside, and that uterus is acting up. The uterus is also responsible for the contractions that expel the child during childbirth. Come on. Oh. Did you unclick me? Hold on. Technical difficulties. Okay, there we go. Did I lose one? Okay, there we go. The lowest part of the birth canal then is the vagina. That actually begins at the cervix. And the cervical canal is the passageway from the uterus to the opening in the vagina. Standard non-aroused vagina is only about 2 to 2.5 inches long. Okay. During sexual arousal, it does grow in size quite a bit, but really, it's a small opening, small tube. Okay. Your external female genitalia, you've got the mons pubis, which is the pubic mound, the clitoris, the pubis or the foreskin, the vestibule, and the opening of the urethra. You probably have seen this before, most of you. All right, so each month, your hormone levels or her hormone levels rise, and very specific characteristic changes take place in her anatomy, okay? One of those deals with menstruation, okay, and that is women getting their actual monthly period. It averages every 28 days. For those of you that have women in your lives, you know that that's not always the case. 28 days is ballpark, all right? Some women are right on a calendar. They can set it every month. They know exactly when their period's coming. Some of them never know when it's coming. Okay, so it's important when we're talking to women who are experiencing pelvic pain and we're trying to get a menstrual history on her, we need to find out, is she regular on her cycle? Is she irregular on her cycle? And if so, how long does her cycle generally last? Average is about 5 to 7 days. Okay, your menarche then is the initial onset of menstruation. Average age, 9, 10 years old. Okay, that's generally when girls first start to get their periods. Menopause then is the opposite side of it. And the women, when they get into generally in their 50s, sometimes in their late 40s, they will start to lose the ability to menstruate. And they are then going into what we call perimenopause, and then they will actually go into full menopause, which is where the ovarian function and menstruation both cease. Okay? That marks the official end of the woman's childbearing years. Although with some of the things that we can do now, science-wise, there are women, God knows why they would ever want to, but there are women that are having babies up into their 60s. All right? Morning. All right, so PMS then. This is the bane of women and men around the world. Okay? Symptoms normally start before their menstrual cycle, anywhere between a week to 2 weeks. Once their menstrual flow then begins, the symptoms kind of alleviate themselves. Sometimes it's easiest just to sit in the back and throw chocolate at them. That helps a little bit sometimes. Based on the woman, some things may help, some may not. Their stress, their diet, their alcohol consumption, drug use, prescription and non-prescription might exacerbate the symptoms. Okay. Mittelschmerz is abdominal pain and cramping. Usually about 2 weeks before their menses begins. Okay? That is thought to be caused by the ovaries actually releasing the egg prior to possible fertilization. If you think about a woman's menstrual cycle, what you've got is you actually have, if you take a calendar month, 28 days, okay? At about the 14-day mark, that's when she ovulates. All right, that's when the egg is actually released and starts making its way down the fallopian tube. If the egg remains unfertilized, it will go into the uterus, and then it will actually pass out with the shedding of the uterine lining during her menses. If the egg is fertilized, then the uterus itself is actually prepared for a fertilized egg. She will not have her normal menstrual cycle. The egg will implant, hopefully high in the uterus where we'd like it, and she will go through a pregnancy. Okay, so the signs and symptoms of this are sharp, stinging, cramping, pain in the lower abdomen, usually on one side, and that one side is normally the side that she's ovulated on. A woman's ovaries don't just, I don't know what the mechanics are of it, but you've got, one will pop an egg 1 month, another one will pop an egg, and then that same one might pop one the third month, and then the other one will, it doesn't exactly alternate. Some women have a single ovary that always ovulates, okay? Just depends on the woman. Amenorrhea is the absence or cessation of menses, and this is more common than you might think. Pregnancy is the biggest reason. You know, you're going to have a 10, 11 month, maybe even 12 month, where she's not going to have a menstrual cycle. Okay? It is also very common in athletes. Okay? Women who get down to a certain percentage of body fat, women who get, they a lot of times will lose their ability to menstruate. And that happens naturally. Sometimes women, we see it sometimes in bulimics and anorexics, okay, where you will ask them and say, when was your last menstrual cycle? And they're like, well, I don't have a menstrual cycle anymore. Really? Okay. That can be a clue. Is that something that's normal? It can also be drug-induced. Okay, a lot of birth control that's out there right now. Things like Implanion, that little rod that goes in their arm. You know, regular oral birth control pills actually account for a menstrual cycle, and so they will get 21 days of a birth control pill and then 7 days of a placebo tablet, and that is when the period actually comes for them. But some of the newer ones, you know, they say, you know, there's no medical reason why a woman needs to have her period. Some of the new ones actually negate it completely. The period just goes away. Other times for amenorrhea, they can have them caused by emotional problems and stress. They can be under so much stress in their daily life that the body just reacts by stopping her periods. So as far as our pathophysiology goes, the disorders in the reproductive system can lead to gynecological emergencies. Now, here's the thing. We need to classify what is an actual emergency. Okay, if she's suffering from vaginal bleeding, how much is she bleeding? How long has she been bleeding? Is it normal bleeding for her? It may not be a true emergency, as opposed to, for example, like an ectopic pregnancy, which is a true medical emergency. Different things can happen, like an acute or a chronic infection. She can be hemorrhaging. Okay, and as much as we might think, you know, I really don't want to see what we've got going on down there, you might need to see what's going on down there. All right, how much is she bleeding? Okay, ovarian cysts can rupture. I've seen women who have had a cyst rupture and it has dropped them literally on their knees. Okay, it hurts that bad. They will clutch their side, they will bend over, and they will go literally down on one or two, on both knees. Okay, or the rupture of an ectopic pregnancy, which is a true medical emergency. All right. PID, pelvic inflammatory disease. This is an acute or chronic infection of the upper female reproductive organs. That would be the uterus, fallopian tubes, and ovaries. Okay. Generally, it will have very bad pelvic pain. It will start low. All right. A lot of times, most women won't complain too much about it. They know that they hurt, but you know, it'll be like, wow, this is kind of hurting. But it will get worse, and it will get worse. The fever will go up. Okay, because they've got inflammation in the lower pelvis. Okay, they can actually go septic from this. Right? It can get bad enough that it can cause sepsis. Your slide tells you about abscess formation. Depending on what's causing it, normally PID is secondary to another issue. Okay, they've got an ovarian cyst, and that causes inflammation. They get a sexually transmitted disease, and that can cause inflammation. It just kind of depends. You can end up with peritonitis, and in some cases, it can even cause them to be infertile. All right, and not just a temporary infertility; it can be permanent. Come on. There we go. Okay. You get it? Yeah. All right. So STDs. A lot of men that I've known who've had STDs get a lot of bravado about it. They'll be like, well, I just went to the doctor, got rotted off the range, feeling pretty good about myself now. Most women, if they have one, the last thing they want to do is tell you that they got one. Okay? They absolutely, I mean, they're embarrassed. They are humiliated over the fact that they got it. They don't even really want to go get tested, but you know, they know that they need to, right? But they don't want to talk about it. Okay, and there are a lot of different STDs out there. So supportive care is going to be our primary means of caring for these patients. Okay, bacterial vaginosis. The vagina actually has a healthy bacteria growth in it at all times. It's very similar to your gut. All right, bacteria is required to keep the organs and linings of the mucous membranes healthy, all right? The problem then comes when the bacterial growth either gets to be too much or too little, or gets invaded by a different type of bacteria, and that can cause itching, burning, pain, might have a smelly or purulent discharge associated with it, okay? Most women will know that there is a change, okay? I don't think that you could have a mucous membrane that is inside your body and then all of a sudden gets an infection and starts to itch and burn. I mean, you're going to know, all right? It's just that she may not want to say anything to anybody. She may not want to go to the doctor. She may not be able to afford to go to a doctor, and so she thinks, well, I'll just figure it out. I'll eat more yogurt, all right? That'll make it better, okay? And if that doesn't work, we'll try to use the yogurt in other ways. That's not going to help, all right? So you pretty much got it, again, supportive care, right? She can have a chancroid, all right? These are caused, I could try to pronounce all these words, but I'm not going to because I won't be that good at it. But it is a bacterial infection, okay? Causes ulcers, not to be confused with herpes. Okay, these are a different type of ulcer, and the only people, you need somebody with the initials MD after their name to figure out, the difference, okay? Those ulcers or sores are usually on her external genitalia, although they might be on some of the internal genitalia as well. Chlamydia, that's the clap. Again, that is a bacterial infection. They may not even know they have it. Okay? And they are communicable to their sexual partners, and guess what? They don't know that they have it either at that point in time. Much easier for men to determine that they have chlamydia than it is for women. Women generally have bacterial discharge. Men don't normally have penile discharge. So when you start getting a discharge as a guy, you're like, whoa, this is bad. I need to go get this checked, all right? Women may not even know, okay? You can have CMV, or cytomegalovirus. All right, this is not herpes simplex 2 or 1, but it is a member of the herpes family. Question? Okay. Like herpes, we don't have a cure. Okay. High fever, chills, headache, you can just feel terrible, extreme fatigue. They're going to have to go and get an ultrasound, and the big thing that there is their spleen will be enlarged. And then the one that we think most about when we think about sores down there are genital herpes. All right, woman gets the herp. We're looking at an infection of genitals, buttocks, and her anal area. All right, it isn't just in the vagina. It can be the entire perineal area. Okay, and it can be for both. Now, here's a question. So, herpes simplex is the virus. One is the most common form. One of you guys, including myself, probably already has one. All right, that's the one that causes cold sores. Okay, and that's very, very common. All right, type 2 is the more serious one. That is the one that we normally refer to as genital herpes. Okay, so here is the question. I have herpes simplex 1. Transmits the exact same way. Open sores, mucous membranes. So I get a cold sore. Am I communicable? Can I transmit herpes to another person? With a sore on my lip, cold sore, active cold sore. What? Makes sense. Okay, makes sense. The answer is yes. The sore is active. If the sore is not active, I have no sore, all right, because herpes comes and goes, it waxes and wanes. When there are no sores, can I transmit herpes? Take a stab. No. No. When a person is suffering an actual outbreak and they have open sores, they are highly infectious or highly contagious, all right? The sores, if you've ever actually seen one, God forbid you actually have them. I was a young, dumb 16-year-old one time and said, don't worry, baby, I won't get it. It'll be fine. Yeah, right, okay? So 30 some odd years later, I still deal with cold sores. But I have no fear when I kiss my wife or my kids of transmitting it if I'm not active, okay? And the same thing with someone who has genital herpes. As long as they're not having active sores, they're not communicable, okay? So a question then, if somebody says, well, I have herpes, okay, and things really hurt right now, ask them, do you have active sores right now? You don't need to see them. You just say, do you have an outbreak right now? Are you having an active sore? Okay. Gonorrhea. Certain STDs come and go. They kind of, again, wax and wane. This is one that has suffered a very large resurgence as of late, probably in the last 5 years. Okay. Gonorrhea can also grow your mouth, throat, eyes and rear end. If it's not treated, it can spread to other parts of your body through your bloodstream. What is the single largest demographic right now? Anybody can answer this. Answer online if you want to. Of individuals, age-wise, that are picking up sexually transmitted diseases. What? Geriatrics and seniors, yes. Uh-huh. All right. Old folks, there you go. Yep. Those individuals that are 65 and older. All right. And that would make sense. You get a pocket of gonorrhea going around the nursing home. All right. Old people still have sex, believe it or not. It's kind of gross to think about sometimes, but they do. All right. But yeah, Altus is laughing at me. Here's the thing: they can't get pregnant anymore. Condom. Why would you wear a condom? Okay. And they're going to think, she buried 2 husbands, I buried 1 wife, we're probably safe. Possibly not. Okay. Yeah. All right, genital warts. This is another one that a lot of women can get, but they don't really like to talk about it, okay? Caused by HPV virus. Okay, or the human papillomavirus. Now we have a vaccine against this guy. All right. So if you know anybody who's an anti-vax, talk to them about their kids, and you ought to at least get the HPV vaccine because that'll keep them from getting, genital warts and HPV. Okay. It is the most common STD. Some people won't have a symptom. Some people will actually have little white pustules all over their genitalia. Okay, they can be internal up into the vagina, but generally the labia and the pubis pons. Okay, has genital warts or HPV, and she delivers a child. It can be passed to the child, and it can actually go to the throat. You can also contract oral HPV through oral sex, male on female. All right. Michael Douglas, very famous, has said that's how he got his throat cancer, which was a form of HPV. He picked it up from oral sex. Okay. Which is, if you take that one step further, that you know that he was Catherine Jones at the time. So things that make you go, All right. All right, syphilis. This guy's been around for years and years and years. Okay. There are paintings from the Middle Ages which show the scourge of syphilis. Okay. The problem with syphilis is that you get the same kinds of signs and symptoms that you would from a normal cold or a respiratory infection a lot of times. And you can remain asymptomatic for a long time. Primary syphilis, you will develop what is known as a chancre, which is a small, painless, open sore. Okay, usually about the size of your little fingertip. Okay, it can be anywhere on your external genitalia. The thing is most people are like, oh, God, I probably ought to go get this looked at, but then it goes away. And you're like, oh, I'm healed. Great. All right, no problem. Secondary stage syphilis comes around, and you start to get these same kinds of sores, but you get them all over your pelvic area. Okay, and maybe up onto your trunk, maybe down onto your thighs. So you're like, yeah, probably. Most people go get looked at this point in time, and they'll be diagnosed with syphilis. The tertiary stage or the late stage syphilis actually makes its way to the brain. Okay, and it can cause psychosis and eventually can cause death. All right, it was very, very common in World War II for soldiers and GIs who went serving overseas to come back and ended up with syphilis. They didn't tell anybody. They didn't go to the doctor, but guess what? They came back, brought it back to their families. Okay? If you look at historically at World War II, some of the posters, some of the stuff, there was, they'd say VD, the big scourge, wrap your soldier kind of thing. I mean, they actually were very open about it because they knew that the men over there were going to go try and find young ladies to have relationships with while they were in the combat zone, and it was running rampant at that point in time. And more than a few soldiers came back and ended up in mental institutions and mental hospitals towards their later days because they didn't tell anybody they had syphilis, and it eventually ate their brain away. Al Capone. Al Capone had syphilis. All right. Trichomoniosis. All right. That is the green-yellow discharge. That's frothy, and it smells really bad. At least according to what I hear. They're going to have, it's very painful to urinate, okay? And so they're going to try not to, which they're going to hold their urine, and that's also going to cause problems, okay? Causes a lot of irritation and itching. But most women can deal with it, all right? The problem is that, again, if she's pregnant, it can be passed to her unborn child. And it says here, low birth weight and premature birth. I don't know how they came up with an increased susceptibility to HIV. I have a feeling that who's HIV positive, and then they come down with this, and then they check their kid, and all of a sudden they've got a pocket of these kids where the mom had both, and now, the kids are actually at a higher incidence for getting the same thing. Here's the one most of us are the most common, your garden variety yeast infection. Again, the bacterial lining, yeah, I see smiles. I can see you smiling up in there too, all right? Garden variety yeast infection, so the vagina has a bacterial colony that lives in it, and that's healthy, okay? When we disrupt that, then it allows yeast to actually enter the vagina and colonize, okay? That is a yeast infection. The itching, the burning, the pain. Now, it used to be you had to go to a doctor every single time. Monostat is the most common yeast infection medication. It's been available over the counter now well over 15 years. Okay, now women don't need to go to the doctor. They used to say, if you think you have a yeast infection, check with your doctor. If you know you have a yeast infection, go to Walgreens. Okay, what is the biggest cause of vaginal yeast infections in women? It's not toilet seats. It's not keeping themselves clean, because most women, believe it or not, do try and keep themselves very clean in their external reproductive area, because they know they don't want an infection, so they do try to stay clean. Antibiotic use. Okay, so if you think about it, woman takes antibiotics. What's it designed to do? It's designed to kill bacteria. Okay, for bacterial infection. And then it disrupts the lining of the vagina. Now yeast gets to colonize. A lot of times there are a lot of women out there who actually, if they have to go to the doctor and the doctor prescribes them antibiotics, they say, can you give me a prescription for Monostat as well, because you're going to throw me into a yeast infection. They already know it's going to happen. Okay, so a good question, if somebody says, I can't take this anymore, I'm itching, I'm burning down there, I don't know what to do, I need to go to the hospital, I always ask them, have you been treated by a doctor recently with antibiotics? Especially young women, because they haven't quite put that together yet. They don't know that there's a causal relationship there. Okay, here's my soapbox. The ruptured ovarian cyst, not the ovarian cyst. We'll talk about that here in a little bit. Ovarian cysts. So what happens is, in the normal course of ovulation, you've got your ovum or your egg, your primary oocyte, or excuse me, your secondary oocyte. All right. It's supposed to be released. How does it get out of the ovary? Well, the ovary actually pops a hole in it. And there goes the egg. Okay. And then the ovary heals itself. That's why a lot of women, when they ovulate, they're like, ooh, yeah, whew, that hurts. And I don't know what's going on, but it hurts. And then an hour later, they're fine. Okay, that was probably the ovary expelling its egg. It's not like there's a trap door on the ovary. Okay, all the eggs are contained there within. The body just ejects one through the surface and the skin of the ovary. Okay, sometimes that doesn't happen all the way through, and the egg gets stuck. okay, and it doesn't quite make it all the way out. Well, the body doing what it does, just like if you've got a splinter on your wrist, and the skin grows over, a little bump or sac right on the top of it, the ovary is going to do the exact same thing. Now the egg is nothing more than a small intruder. Okay, so just like an oyster making a pearl, it's going to make a little cyst. Well, it's going to send white blood cells to it. It's going to send, it's going to use the body uses its own defense mechanisms against this little mini intruder, and it develops this cyst. Okay, and then at some point in time, the wall can't take it anymore, blows. Okay, these are the ones I talked to earlier, where a woman might have one, she might not know she has it. There's no pain, no nothing. Then all of a sudden, it feels like a gunshot just went off in her lower abdomen. All right, and she will bend over, she will double over. Sometimes it'll drop her all the way to her knees, and you'll be like, "What's going on? What's happening?" And she's like, "I don't know." All right, incredible lower abdominal pain, usually on one side, moving around to the flank, sometimes in her back as well. These things can be baseball sized, maybe even depending on how big they grow. And if a woman has one, very common for her to have another one. So you ask, do you have any history of ovarian cysts or any problems with your ovaries? Okay, as part of your secondary evaluation when you're going through your OPQ or ST. All right, and your sample history. They might be large enough that she actually has to have it removed. And this is a big decision for a lot of women, because if it's that bad, a lot of times they're going to take the ovary as well. They'll leave the tube, but they'll pop the ovary. All right, they'll take it out. Now, just like our testicles, you can survive with one. She can still reproduce. All right, she can still have kids. All right, might be a little more difficult because the system's designed to work with two, but she can still do it with one. Okay. Big thing for most women is if they have one ovary that doesn't function well, okay, which is common. The other one might have ovarian cysts. They have to remove that one. She, at a very early age, may not only end up infertile, but if the one ovary isn't working well to begin with, she may start going into perimenopause or become menopausal, sometimes very early, maybe even before the age of 30. Okay, cessation of periods. Hot sweat, her night sweats, hot flashes, all of those things that women associate with that later change in life. Okay, sometimes when they burst, they can bleed quite a bit. It's rare. All right, but check their blood pressure, see what they're doing. All right, if her pressure is bottoming out, there's a good chance that something popped in there or something happened, and she's got some internal bleeding. Okay, and so you're going to need to treat for that. All right. Here's my soapbox. Ectopic pregnancies. Write this down. If a woman has lower abdominal pain and she is of the age to be sexually active, which is from the age 10 or 11, it is an ectopic pregnancy until proven otherwise. If she lies to you and says, sex, what's sex? I don't know. What is sex? I can't be pregnant. Don't buy it. All right. I got burned on this one time. Very close to getting burned. Had a young gal. She was probably 14 years old. She had lower abdominal pain, moving around to her flank. She's like, I'm not really sure what's going on. Her mom and dad are there. Her mom's caring for her. And she's like, well, she has some problems with her period, but she's young. So she hasn't really gotten, on her cycle yet. I was like, oh, okay, that makes sense. I don't know a lot about this, so yeah, okay, I'll go with that. So then what happened was I made several mistakes. The first one was I actually wasn't going to transport her. I said, okay, well, I think we're probably fine. All right, you want to just, stay home and just put like hot packs on it and a heating pad, see if it gets better. And she actually said, I've already done that. Okay, so which should have been my first clue. All right. So we decided to transport. Second mistake, I left mom in the back with her. Okay, I didn't separate them, which I should have. I should have put mom up front and said, Mom, I'll just have you right up front, and I'll be back here with her. All right. Had I done that, she would have probably felt much more comfortable when I asked her, like the first time in front of her parents, are you sexually active and have you had sex lately? All right. What's she gonna say? She's gonna do what I do. What's sex? No, I don't do that. I'm a good girl, you know. But if I had her mom elsewhere, I could have just been taking notes. Back then we had to take notes, pen and piece of paper, okay? But I could have been just taking notes and said, all right, by the way, your mom can't hear right now. Here's what I want to know. Are you sexually active? And is there any chance you could be pregnant? Okay? I said, just nod your head, yes or no. She could have just nodded her head, and I would have had a clue. So I get her to the hospital, and I say, I turn her over to the receiving nurse, and I say, she's got some lower abdominal pain. She's 14, menstrual cycle's not really set yet, you know, so we're thinking maybe menstrual cramps. She is kind of complaining about being it on one side, but I'm not really seeing anything, no fever, no nothing like that. And so the nurse was like, okay, and everybody was just kind of like walking through. Easy does it, you know. She had an ectopic, burst in the ER. They barely got her to the OR for surgery, and I mean, she survived, but we would have been moving a whole lot faster. And the doc caught me later, and he was like, what made you think it wasn't an ectopic pregnancy? I was like, well, you know, she's 14. She's like, you know, girls are sexually active all the way down to the age of 10 or 11. So I told myself, I said, I'll never get burned by it again. All right. It requires an ultrasound to find it. So just keep that in the back of your mind. Don't make the same mistake. All right. They might have vaginal bleeding. They may not. And as you see here, it is the leading cause of maternal death. Very, very vascular area. And when the fallopian tube explodes, it's fatal to the fetus at that point in time. You know, the baby can survive that, obviously, because it's implanted outside of the womb. But literally blows the fallopian tube apart, and she starts bleeding and hemorrhaging inside. Okay, lower abdominal internal bleeding. All right, so what causes it? Well, you've got that ovum that's trying to make its way through the fallopian tube, and it's kind of moving around, and all of a sudden it gets stuck. Okay, sperm from the partner makes its way up through the cervix, up and you know, I don't know if you guys remember this or not, but fertilization actually happens in the fallopian tubes. All right, that's where it's designed to happen, at least. Okay, so sperm makes its way up through the cervix, up through the uterus, makes its way into the fallopian tube, finds that ovum, boom, we have a zygote. Okay, that zygote continues to travel down, and it's supposed to get into the uterus and then implant itself. By then, it's probably a ball of cells that might be, you know, several 100,000 cells. Okay, when that goes wrong is when it gets stuck. Okay, so let's say she's had to have surgery before, and she ends up with an adhesion. You guys know what that is? You ever see that? You have, you just don't know it probably. You ever see somebody who's been burned and they have what we call keloid scars? Those big, thick, nasty scars. Well, inside you, after you have surgery, those scars, which might cause one part of your abdominal organs to maybe hook to another, all right, those are called adhesions. They're basically an internal keloid. Okay, so and they're very common in surgery. Okay, somebody has to have an abdominal surgery, have an appendix out. Okay, common problem. Okay, they could have pelvic inflammatory disease. They can actually, from tubal ligation. Okay, this is a good one. They used to, what is tubal ligation? Anyone out there in internet land? I'll give it a minute. Give it a minute. Nothing? It's like crickets over here. All right. Woman gets her tubes tied. She gets medically sterilized. Okay, it's like getting a vasectomy for a man. All right, except that old school ligation, they used to go in there. They used to literally cut the tubes, tie it off, call it a day. Okay, and it was reversible at that point in time. Then, in medicine, because it's always evolving, they decided that the thing to do would be to not cut the fallopian tube anymore, because well, we can avoid the bleeding. We just tie it off. Okay, and now that has evolved to clamps. okay, where they will actually go in. Normally it's done laparoscopically, or like if she has a C-section, they'll do it while they're in there for a C-section, okay? And they will go in and they will just go clamp, and drop a clamp on either one of the fallopian tubes. Well, all of us that have ever used a clamp on something know that it can loosen up, all right? And sometimes that happens. Sperm is a single cell. Half the DNA of the human being that put it out there, but a single cell. And it's got a motor, all right? And its sole job is to figure out a way, all right? Kind of like Jeff Goldblum in Jurassic Park. Life finds a way. And so it's possible. She's still ovulating all this time. It's just the egg can't make it there, okay? So sperm manages to figure out a way past the clamp. Boom, all right? And we have a tubal pregnancy. Another common cause, although it's actually rare that it happens because of it, is an IUD. All right? These used to be a very common form of birth control. Then they went off the market because a lot of women were suffering uterine rupture and some other problems with them. And so they said, well, IUDs aren't safe. We can't use them. The advantages of an IUD for birth control are obvious. You can switch it off in a matter of a doctor's appointment. All they got to do is just go in there and remove it. All right? It doesn't hurt anything. It's not painful. It doesn't bother the woman who's wearing it. Okay? And you can have natural intercourse. There's no barrier. Okay? So a lot of couples opt for that. The problem with it is that it can cause some of these other problems and irritate the upper reproductive system to the point where the fallopian tubes can become irritated, swell. We know that swelling can cause a tube to close, just like on a trachea, or not a trachea, but just like, in your oral pharynx, you get a lot of oropharyngeal swelling, can cause that to close down. Same thing with a fallopian tube, okay? And so it can get stuck that way. Vaginal bleeding. Well, any questions over STDs, ectopic pregnancies? Anything from out there? I'm going pretty fast, so. Coulter, no. All right. Okay, let's talk about vaginal bleeding then. Another mistake I made one time was I thought that the gal said, well, I'm bleeding down there. I was like, okay, you're bleeding down there. Probably normal. Women are supposed to bleed down there. I'm sure it's nothing. Okay? Don't assume that she's just on her menstrual cycle just because she's suffering from vaginal bleeding. It's pretty easy on a 75-year-old where they say, oh, she's suffering from vaginal bleeding. And you're like, she's 75 years old. Must not be menstrual. All right. Any bleeding during the third trimester of a pregnancy is to be considered very serious. Okay. All right. This is not going to get too much into obstetrics. I don't get to teach obstetrics. But let's talk a little bit briefly about placenta previa and placenta abruptio. Okay, or an abrupted placenta. Okay, what is placenta previa? Think back to your EMTB, because remember, delivering and birthing babies is an EMTB skill. Okay, so think back. You remember what it is? I'll give you a minute. Don't look it up. No Google. Just because I can't see you, don't think I don't know what you're doing. Church, placenta previa. Oh, you're killing me. I don't have a whiteboard here to draw on, and they probably wouldn't like it if I drew on the wall. All right. Is there? Okay, that would be nice. The thing gets the stuff. No, that's not how it works. The thing gets the stuff. Damn. All right. Egg comes down through the fallopian tube, hits the uterus, implants. All right. Now we know that as the fetus develops, it has a lifeline, its umbilical cord, attaches to mom. Does it attach directly to mom? No. What's it attached to? Yeah, Max, what is it attached to? What?
Can you repeat the question?
I can repeat the question. The umbilical cord is attached on two ends. One is to the infant, the developing infant. The other attaches to what? The placenta. Thank you. No, we're good. All right. So the placenta is necessary. That's how baby gets its nutrients from mom, okay? And the placenta is actually expelled during the third stage of delivery, or the third stage of labor and delivery, all right? Those of you that have kids or have seen that, it's like, wow, that's much bigger than I thought it would be, okay? But that placenta then, all right, wherever the egg implants in the uterus, that's where the placenta is going to grow. And it attaches itself to the uterine lining, and then that's the barrier, the uterine placenta barrier, okay? That's the child's first line of defense against infections, everything else, okay? And you'll hear people, when they say, well, what is this drug? Does it cross the placental barrier? Okay? That's where it's hooked to, all right? So that placenta, there's no rule that says it has to be anywhere in the uterus. It could be high, it could be in the middle, it could be low. Placenta previa is where it attaches so low in the uterus when the zygote implants, okay, that it actually covers the cervical opening. So when mom gets ready to deliver, guess what's in the way? She can't. The cervix can't open up enough because the placenta is covering the cervix and the child's head can't pass through, okay? Previa. It's like a preview, like, the placenta is the preview to the kid, all right? These are an automatic C-section, okay? They will end up going in and they will end up getting a C-section. And they'll find that ahead of time. They'll find it by ultrasound, okay? They'll just say, you know what, your placenta's too low. I'm sorry, we're going to have to do a C-section on you, so we're going to take the baby at, 37 weeks or 38 weeks or whatever it's going to be, okay? Abruptio then. Now, we've got the placenta, it's attached, everything's good. Mom decides that she wants to, I don't know, she doesn't have to be super active. But she does something. She bends over to try and pick something up, stands up, and the placenta tears away a little bit from the lining of the uterus. Okay? That is a problem. Up until it's designed to come loose, it is probably one of the most vascular areas in the pregnant woman's body, is that blood barrier between the uterus and the placenta. And when that placenta tears away from the uterine lining, it actually causes copious amounts of bleeding. Okay? Now, think what else in there. I mean, it's limited real estate, right? It's a little room in there that the baby's growing up in, up until now. Couple that with the fact that you've got a 9 or 10 pound, well, 9 or 10, probably a 5 to 8 pound infant. You've got a couple pounds of amniotic fluid in there. The kid's in a sac, all right? You got a placenta in there, all right? That blood actually has to make it all the way around all of that and then figure out how to get out of the cervix, which is the hole in the cervix without dilation is probably only about the size of a standard pencil or pen. It's about that big around, okay? And she's going to start bleeding. Now, what color is this blood going to be? Bright red. Unless I've forgotten, but. All right. Come on. There we go. It's this one, I know. As I'm looking at that one. Yeah. All right. Bright red blood from the placenta is a very serious concern. Or from the placenta, from the vagina is a very serious concern. Okay? If a woman is pregnant, you're going to have your pregnancy questions. Okay, is this, first baby, second baby, third baby, what is it? How many times have you been pregnant? We want to know para and grava. We want to know all of the other questions that go along, and you'll get more of that when you get into your obstetrics lecture. But just know that if she's not due yet and she's suffering from heavy, bright red vaginal bleeding, and she's in her third trimester, it's not the time to wait. Let's just get on the gurney and we're going to go to the hospital. Okay? She needs labor and delivery, and she may need surgery at that point in time. Okay? And so for you guys, fluid replacement. Okay? I'd start a line. I'd start at least a slow drip. Okay? Because we don't know how long it's. Because the other thing about that is, gravity works, but gravity's not just going to automatically take it and shed the blood straight down. It's got to go around the amniotic sac. It's got to go around the infant. I mean, it could be up high, and it could take a while to work its way down. All right. Okay, so our causes of vaginal bleeding: onset of labor, of course, ectopic pregnancy rupture, PID, other infections, trauma. And then lesions, we've talked about all of these so far. Any questions over vaginal bleeding? All right, I was going to do a science experiment for you guys, and then I opted not to do the science experiment. And we'll talk about it a little bit when we get here, as far as vaginal bleeding and what constitutes serious vaginal bleeding and how you can tell. All right, and I think it comes in after we start talking about conditions of the female reproductive system. The first one we're going to talk about is endometritis. Itis meaning what? Inflammation. Endometri. A little more specific. You're there. You know, of course, I've only told you about 4 different parts. So, I mean, you got a 25% chance of being right there anyway. Okay, the endometrium, all right, which is the lining of the uterus. Okay. So endometritis is inflammation or irritation of the endometrium, most commonly caused frequently by STDs. Antibiotics will fix it. She might get a yeast infection because of the antibiotic, but it'll fix it. Left untreated, again, we're looking at possible shock, possible spontaneous abortion or miscarriage. Okay? If she's in her early stages of pregnancy and the lining of the uterus gets cranky and angry, it might say, you know what, we're done. Get rid of everything. Okay? Not uncommon. As opposed to endometriosis. Right? This is where the lining of the uterus, and when we say the lining, I don't want you to think that it's like this isn't like some creepy crawly skin looking thing that grows outside of the uterus and moves around and just like a blob kind of takes over the ovary, then the fallopian tube, then works its way down to the bladder, works its way around to the colon. That's not it, okay? What you actually have is at the cellular level, endometrial cells which have gotten out and have started to grow little pockets of endometria where they're not supposed to be, outside the lining of the uterus, okay? This is a big thing for women, all right? It's a very common problem. And the big one that we run into is it causes very severe pain, okay? Normally, it's going to be in the lower back, the pelvic area, and the abdominal region. Pain during sex is a big clue, okay? If a woman is trying to have intercourse and it hurts terribly, okay? Not like from the sex itself, but her whole lower abdomen hurts, okay? That's what they're going to check her for. They're going to take a look and see if she's got endometriosis. They'll put her under, not under, but they'll go and do a ultrasound on her and see if she has growths. Endometrial growths, okay? And it's a big cause of infertility as well. You get endometria that grows around on the tubes, it can block the fallopian tube. They're infertile, all right? It can get in the fallopian tube and cause a blockage. That's infertility. It can hit the ovary and grow around the ovary. That'll make her infertile, okay? And it hurts the entire time as well. Postpartum eclampsia, all right? Baby's born, mother's at risk for eclampsia for several weeks. Preeclampsia and what makes the difference? You don't get the answer. What's the difference? We can say a woman's preeclamptic. What do we got? We got a higher blood pressure. Okay. And that's our hallmark symptom. Okay. But, you know, the other symptoms that go along with preeclampsia. But she's missing one thing that makes her actually eclamptic. I'm waiting. It's in the slide, if you're looking at the slide. All you got to do is look. Nobody's typing either. What is it? No, not before the baby's been delivered. It's the second one. First word, second sentence. There it is. Thanks, Coulter. If she's preeclamptic, she hasn't had a seizure yet. The minute she has a seizure, she's got eclampsia. Okay? And she is subject to seizures and eclamptic symptoms, the hypertension, after she's had the baby. Postpartum is after the baby's been born. Okay? As opposed to prepartum. All right? Paramedic backup is required on this one. I kind of chuckle on this. I don't know why. Well, no, I understand to treat the seizures. Do you have enough in your med kit to treat an eclamptic seizure and to break a seizure? Do you carry enough mag, though? Because eclamptic seizures are not like breaking a regular seizure. Ish, yeah. So the amount of magnesium that's in our medic bags may or may not be enough to break a seizure on an eclamptic female. It takes a massive dose. And I don't know about a postpartum female. Is there a difference on that one?
I would say the trio, the big three
Mm-hmm.
here, the 10-minute transport.
Yeah. Yes.
It's the quick-ish.
Uh-huh.
We can start it.
Right.
You're right. We have to be close.
Yeah.
And they have to be there.
Yeah. So.
The other thing is when you're looking at physical signs, we got blood pressure, but excessive weight gain. And it's not just like, oh, I'm pregnant, I'm gaining weight. You'll see fluid retention, something to kind of be considered. So look for the extremities, lower extremities and stuff.
Okay. Pedal edema. All right. Get a medic coming. We're fortunate on the big three that we got medics everywhere. You can't swing a dead cat and not hit a medic in this county. All right. Until you get in the outlying areas. But that's awesome. Because I will tell you guys, as advanced level providers, you're going to get good. You're going to get better. Okay. And you're going to come a time where you'll be like, nah, I don't need that medic. You know, I got this. And you're going to find out about 5 minutes from the hospital when all of a sudden your patient starts going, woo, woo, woo. It's like, I ain't got this, and I already sent my medic away. Because it happened to me a couple of times. Yeah, be thankful that they're there, because they'll tell you almost to a person, just call us. We'll make a determination. We'd much rather be called and not needed than needed and not called. Okay? All right, sex assaults. Sexual assault is one of those types of, well, it is a crime, first off, okay? This is one of those calls that I would encourage you, if you're not a writer, learn quickly, or dictate everything that you saw and take the time to write it out. If it is a legit sexual assault, you're going to have to talk to somebody somewhere about it, okay? It's a reportable crime, and you're part of the chain of evidence, okay? So, what did you see? What did you hear? Now, there's a couple caveats to that, and I'll tell you a couple stories, not super long war stories, but most of our victims of sexual assault are women. They can also be men. They can also be children. Okay? We want to be compassionate. We want to transport them. Some of these guys and gals will have multi-system trauma. Okay, they might be suffering from tearing and bleeding, of the external genitalia, okay, where they were assaulted. All right, it is not just rape. Okay, I've seen beer bottles used as assault weapons. Okay, anal and vaginal. I've seen beer cans. I've seen boots. All right, I've seen fists. All right, all of those cause tearing, bad bleeding, and that's the kind of stuff that, there are dirtbags out there that try to do. You need to get an accurate and detailed assessment of your patient. All right. Try to figure out how sick they are and whether you need to initiate things like IVs, whether you need to initiate rapid transport. All right. I had a captain once that would tell me, the ambulance has wheels for a reason. All right. It's not to sit on scene. Okay. That is still our number one intervention that we do is transport. Okay? So do not be afraid to just load them up and take them to the hospital. Whoops. So our primary assessment.
Remember, when you have a sexual encounter, sexual assault, use my word, that the evidence collection, so they'll, close those kind of things, make sure we're bagging it up correctly.
Mm-hmm.
Because, it's evidence. So if they are battered and bruised, and you want to cut clothes and stuff, make sure to try to preserve as much as you can.
Yeah.
Forensics will need that.
Don't cut through, like, if there's a hole, like a knife wound or something like that, and it was stabbed through them, don't cut through the hole, cut around the hole, those kinds of things. Okay. Get a decent general impression. If they have a weak rapid pulse, pale, cool, diaphoretic, put them in a supine position, cover them, keep them warm, rapid transport. Okay? Try to get their chief complaint. Your gynecological emergencies, often the signs and symptoms often mimic other things, so be very cautious against discounting it as a gynecological problem. So, she's probably just got gas. She's probably, she's a woman, she's going to have cramps. Don't go down that road, okay? It's a dangerous road to travel because the minute you start doing that, you're going to not think about the other things that could be going wrong, okay? Get the nature and extent of the problem, and then ask them about previous episodes. Now, that's not on a sexual assault to say, well, when was the last time you were raped? Okay, all right, that's not, and the time before that, so you've been raped probably once, what, you say every 2 to 3 weeks? It's not, all kidding aside, that's not how it's going to go, all right? But do ask, have you ever encountered or have you ever had any issues like this before or something along those lines? Tact is the hard part here, okay? Ask about a history of gynecological problems. Ask if they use contraception. Okay? For men, it's easy. You got condoms and you got, okay? Or not doing it, pulling out. Women got a ton of options, okay, as far as contraception goes. They got the pill, okay? And that can either be estrogen or progesterone, okay? They've got implants that they can use. They've got IUDs that they can use. There's female condoms that they can use if they want to go that route. There is, I forget what the other one is. There's shot, the depot shot. It's like a 6-month shot. We're up to 7 now, and there's more out there, okay? There's a lot of different options. Educate yourself on the types of birth control that they can use. A lot of women do not consider their birth control as part of their medications. You'll ask them, say, are you taking any medicines? Do you take anything prescribed by a doctor? No. It's like, okay. Are you on birth control? Yeah. Okay, well, what birth control do you use? Oh, I'm on the pill. Okay. But you don't take any medications? No. It's like, okay. All right. What not medication birth control is it that you take? All right. And just go that route. Again, consider possibility of pregnancy in any woman of childbearing age, even if she uses contraception. My ex-wife was a product of what I used to laugh and say, you were a product of a night of drunken lust, but her mom always said she was on the pill when she got pregnant. Right? It can happen. That's that whole 98.6% effective. There's still a 1.4 chance that it's going to be non-effective. Okay. Address any trauma, any significant trauma. Okay. Your secondary assessment, you might do it at the scene, you might do it en route in the ambulance, you might not do it at all. Okay? As far as a physical exam, you've got to be tactful about this. All right? If she's suffering from major vaginal bleeding or major vulvar bleeding, because she was assaulted, we're going to have to deal with that. Right? We're going to have to deal with the bleeding. That doesn't mean we got to get all up in there, but it does mean that we need to try and fix it. All right. It would be no different than if she got her finger cut off or if she dropped a kitchen knife on her foot and cut an artery in her foot. She's still bleeding badly. We need to at least try to control the bleeding. Okay. However, maintain her privacy. Our ambulances are awesome during the daytime at maintaining privacy. They are terrible at night. Okay. You guys all know this. You can see like it's daylight in the back of an ambulance at night. Okay. So do what you can to maintain her privacy. If that means you say, look, we got to get you out of these clothes and I have to examine you, put a sheet over the top of her, then help her get out of her bottoms, and then do the exam real quick. Okay? Focus on the nature of the illness and the patient's chief complaint. Get a good baseline set of vitals. Watch out for tachycardia, tachypnea, things like that, because those might be a change. Remember, we're going to take vitals if it's an assault and she's stable, every 15 minutes. If it's assault and she's unstable, every 5. Or anytime we have a significant change in vitals. All right, that's going to be the other time when or a significant change in her presentation. We'll pop another set of vitals. Okay. Note the color, the amount of bleeding, and/or any discharge. All right. Is it purulent? Okay, meaning does it smell really bad? Okay. Is there color to it? Okay. Most women, you're not going to get down there and take a look at her vaginal discharge and see what it is. So if she says it's green and it really smells bad, take her word for it. You know, because I, for one, I'm not going to go, well, I need to take a look. Not my job, you know.
Also, when you talk about amount of bleeding, a lot of people are like, how do I know? Typically, we talk about that.
Yeah, we're going to cover that. I got that. I got it. Yeah. All right. So then, for our interventions, we're not going. There's not a lot you can do, and there's not a lot you probably should do. Okay. Again, not our place, especially in a sexual assault. Let's talk about that real quick here, because it doesn't really get into it in the slides. The hospital tries to do a very good job of having sexual assault coordinators and clinicians. Okay, so let's say we get a young woman. Oops, I want to break that. We get a young woman who was raped. Okay, we know it's an obvious sexual assault. Okay, in my patch, I will talk to the hospital and I will say, "This is Medic 32. I'm inbound with a 24-year-old female. Chief complaint is vaginal bleeding. I need you to get me an SA." All right. That tells the hospital that you have a sexual assault and that they need to get a sexually assault trained nurse ready to go. What that nurse is going to do is they are going to meet with you. They are going to be the one who takes your report. They are going to be the one that is in the room, and they're not going to leave her. They will go with her to ultrasound. They will go with her. They will be the one to collect the information. They will do the rape kit so that there is one person who is with them the entire time. Okay? Now, like Shane said, you're dealing with a crime. I mean, and I think any guy worth his salt wants the dirtbag who did it punished or caught and have them face retribution for what they did. All right? Because I know if it was my female family member, I'd be like, oh, no, we don't. You know, the best thing we can do to try and make that happen is to document and preserve everything we saw, heard, and then like Shane said, like clothes, if they have to be removed, we take those and we say, here's the clothes. We don't allow them to shower if we can at all help it. Okay? We try to keep, and because she's the evidence at that time. The only way we're going to catch whoever it is with forensic evidence, and that has to come from what was left behind. Okay? So we're not going to do a lot of interventions, but there are some that we may have to. Treat her for hypoperfusion and shock, maybe start on IV, okay, if she's hypotensive. All right. Keep her warm, put her in supine position, give her oxygen, transport. All right. There we go. En route to the hospital, recheck your primary interventions. Make sure, again, communicate to the hospital staff. Look, I need an SA nurse, or I need, I've got a SA here. All right. Document everything, especially in cases of sexual assault. There's a very good chance you're going to be called to the witness stand sometime in the future. It could take several years. All right. So make sure that you can look at it and say, I mean, there's a good chance something like that's fairly traumatic for us too. You probably won't forget it. Probably be kind of seared in there. All right. Be one of those calls you just don't forget. But write your report as if you will have zero memory of it, so that when you look at it again, you'll be able to go, oh, okay. Yeah, I remember exactly what happened. Okay. All right. Maintain their privacy and modesty. We kind of beat that one up a little bit. Gain their confidence, all right, by communicating appropriately, answering their questions honestly. Okay. I haven't had too many sexual assault victims. The one that I've had, or the that I've had, most of them have been very quiet. They will answer your questions, 1 or 2 word answers. They don't want to talk, you know. There have been a couple of them that have been very emotional, which I think is to be understood. Okay. This is the time to pull out whatever supportive care you've got. Okay. And if they ask you, what am I supposed to do now? Or what is going to happen to me? Or what's going to be the next step? Be honest with them. Say, we're going to go to the hospital. We're going to get you into a room. They're going to get you with a specific nurse who's trained to handle these types of situations, and she will guide you through the process. But it is going to be a process. And tell them. Okay? And be honest and say, look, the only way we can make this any better is for you to try and go through this process with, and see it through to the end. Okay. Sanitary pads, period pads, whatever you want to call them. That's what we got to use on the external genitalia to absorb blood. Now, how much is she bleeding? How much does a pad hold? You know, a big pad, like an overnight pad, all right? You guys are all old enough to know about menstruation and pads. You've all seen them in the stores, all right? Some of those Hummers are about that long. The ones that they use postpartum for a woman that's just had a kid, they're about that thick and about that long, all right? They're huge. They're not that big, but yeah, they're big. I filled one the other night just to see so that I could do it for a demonstration. This is what I got into one before it leaked and overflowed. That's 2 ounces. Okay. This was a size 4 out of like a size 5, I'm guessing. You know, 5 would be like super duty, heavy duty overnight. All right. I would say you're looking at between, what, 2 to 4 ounces per? Somewhere in there? Per pad? I know that you can get 2 in a big 4. All right. It's going to depend. You need to ask a little bit and get a little information. Say, okay, what size pads are you using right now? Okay. Are they for lighter flow or are they for heavy flow? All right. If she says I used a pad for heavy flow and I'm filling one about every half hour, that's 2 ounces minimum every half hour. How many ounces are in a pint? Anybody know? Where's my cooks? How many ounces in a pint?
I think most of the people that are listening deal with pints.
Right. Pints and gallons? Yeah. Go out to the brew pub. There you go. Good job, Churchy. 16 ounces in a pint. I wonder how you knew that. That's weird. All right. So 8 pads is a pint of blood. That's the same amount that you donate when you go to donate blood. All right. You got 4 to 6 quarts, 2 pints per quart. All right. In your circulatory system. How long have you been bleeding? And how long have you been bleeding this heavy? You might have to do some maths. All right. Write it down. Do it. But it's possible that she's lost a couple of pints of blood by the time she finally called you. All right. It takes a month for your body generally to replace a pint of blood. All right. So 1 month at a time. If she's lost 2, she's hypovolemic. That's how you're going to have to do it. You know. Put them on their left side. External lacerations, abrasions, tears, sterile compresses, 4x4s. If we've got tears and rips downstairs, don't just grab the brick of the non-sterile 4x4s. At least put a sterile one on first and then put the non-steriles on top of it. Okay? You probably need trauma dressings at that point in time. Now, a 5x9 or a, what is the big one, the 10x17, the 10x10, whatever it is, you can fold those up and make those into emergency sanitary napkins. If you had to, just fold them in half, all right, and use that, all right. I don't know how much fluid, though. We ought to do that sometime too, figure out how much a 5x9 holds in ounces. Be curious, okay. There's a rule in EMS that says never put your finger into somebody else's wet hole. That applies to this one too, okay. No circumstances, we don't pack or place dressings inside the vagina. All right, that's not our position, not our place. Okay, if the hospital wants to do that, they can do that. Always assume that she could be pregnant. 11 to 70, she could be pregnant. All right, so be possible. Be prepared that maybe she's miscarrying. She might be spontaneously aborting. Do women always know that they're pregnant? No. I'm not sure how you would know. Or how you wouldn't know sometimes, like when you get into the late stages of pregnancy, you know, it's like, oh, I just had a baby. I didn't even know I was pregnant. Really? Okay. I don't know how that works. But at the same time, not uncommon for women to go a couple of months. Okay. Let's say she gets pregnant, misses her period, but she's not normally, she doesn't have a normal cycle. Normal cycle. Okay. So it's no big deal. All right. Wow, it's weird. My period never really came, had a couple spots. Maybe that was it. Okay. Another month goes by. All right. She's waiting on her period. She's like, wow, this is weird because normally I would have at least seen something by now. And, you know, she's maybe not getting the morning sickness, maybe not getting any of those secondary symptoms of pregnancy. She could be 45 to 60 days in before she finally puts 2 and 2 together and says, you know what, maybe I need to go take a pregnancy test. Okay. Because I'm not seeing anything. And in the meantime, she could miscarry. Very common for women to get pregnant, physically pregnant, okay, and then have what they consider to be, wow, it's just a really heavy period. Like a month, month and a half later, they miscarried, didn't even realize it. Okay? Body just didn't take. It just didn't take for whatever reason. Okay? All right. Any questions from online? Doesn't look like we got any in here, but any of you guys out there in the internet world got any questions? Like I said, been moving pretty quick. These guys get breaks? Do they not get breaks? Okay, well, we're going to take a break. Let's take 10. You guys getting it? Not feeling picked on, are you? All right. This ain't our first rodeo. All right. All right, so how do we manage these things? Well, PID, again, we got lower abdominal pain. Maybe they have a fever. They got a discharge. Dyspareunia, excuse me. They're generally going to be doubled over when they walk. Okay, they're guarding, seriously guarding. Okay, put them in a position of comfort. You might transport these gals on their side if it's easier for them. Where they can bring their knees up to their chest, and then just transport them. We go pressing the wrong button again. I got it. That's okay. Okay, for ruptured ovarian cysts, again, sudden onset of lower abdominal pain. Might go into the back. There may be some vaginal bleeding. You're just going to have to go on what she tells you, okay? Your hallmark symptoms on this is everything was fine, then all of a sudden something went, I felt like something popped, and it was incredibly painful, okay? Ectopic pregnancies, they're going to show signs of hypovolemic shock. Bleeding may be quite a bit. Monitor them for shock. Do a set of orthostatic vitals. Do a tilt test on them. Okay. This is an actual medical emergency, so transport them to the closest appropriate facility. They may just be having a really, really heavy period, and it's odd for them. Okay. That's what Amenorrhea is. Okay. Always assuming the bleeding the first or second trimester could be a spontaneous abortion. Okay. If they are bleeding in their third trimester, again, that is serious. They need to go into the hospital. They need to go to L&D so that they can take a look. Okay. Find out when everything started. Okay. Well, it started with some spotting yesterday, and it's steadily gotten worse. So you've been bleeding now for 24 hours plus. Okay. That's the kind of thing that you need to find out. Okay. For sex assaults, again, the most common of sexual assault is rape. We don't have that option very well in the county here, but do try, if you have the ability, to put them with a female EMT, if you can. All right. Be professional, be tactful, be very kind and sensitive. If you do have to do a physical exam, keep it brief. All right. Don't be sitting down there, taking a good look. All right. Just see what you need to see and then be done with it. Your first issue is the medical treatment of your patient. Second is the psychological care of your patient. Believe me when I say, it's kind of like a hospice transport. Okay? They will remember everything you say and do in that situation because their brain is on overdrive at that point in time. And if you make some what you think is a funny comment and they perceive it to be snarky, or if you say something that could be taken the wrong way, they're not going to forget it. Okay, so be very cautious about how you approach the situation. Just, think of it as if it was your sister, your mom, your daughter, your wife, whoever an important woman is in your life, and treat them the way you would want them to be treated. Treat your patient that way. If your patient refuses transport, just follow your local protocols the best you can. If you suspect that the patient was maybe date raped, all right, they got roofied, okay, remember that that is also part of that chain of evidence, okay? If the drug is still in the system, you get a medic on the way, okay, for sure. and you might need to be ready for, they might be hypotensive, they might have difficulty breathing, could be unconscious. Okay, women that I know who have experienced that have said things like, I woke up in a parking lot and had no idea where I was. All right, they were absolutely just gorked. Okay, don't know how they got there. Some of them will talk about how they woke up in the middle of the assault as they were being passed around between multiple men, and they wanted to stop, but they just couldn't even make words. They were that out of it. Okay. Vaginal foreign bodies, things like fisting or insertion of live animals. I don't know why they went that far on this slide, but they did. But just know that there are practices out there that most people probably won't engage in, but there are some people, they will engage in stuff that you're just like, where did you even get that from? Okay. Matter of fact, when I was getting checked off, when I was back in Virginia and I was getting checked off to ride an ambulance, and I was trying to become what we called an aid man, which meant that you could run solo on an ambulance. We went on a couple and they were inserting ostrich eggs, or attempting to insert ostrich eggs into each other's anuses. All right. The guy had managed to make it with a rather large egg, not an ostrich egg, but he wanted us to pull it out because it was very painful. And we're like, not doing it, dude. So, and that's it for this one. Yeah. I ain't doing it. All right. Any questions over gynecology? It's pretty cool. It's like using the Force. All I got to do is just look at the TV and hopefully it'll come up. Go to the E. There you go.
What are we doing? 26.
26. I hate it for whoever has to do pediatrics. You guys get into that chapter yet? That thing is huge. Thank you. Not going to worry about that. Not going to worry about that. Not going to worry. We'll worry a little bit about that. We're going to talk now about your trauma overview. There's a lot of stuff in here, but a lot of it is stuff that you've already seen. Okay. They are going to take what you learned as everything at the EMTB level and just bump it up a notch. Okay. So we will talk a little bit more about multi-system trauma. We'll talk about some blast injuries. Unintentional injury, primary cause of death and disability between 1 and 44 years. Okay. And all of us who have been in the county and been working on buses long enough have, we don't see significant trauma all the time, but we've seen some significant traumas. And those are the ones like, usually you're like, that was really, really cool. All right. However, we got to know how to deal with these. Okay. And this is where we make our money, so to speak. Okay. Proper good evaluation in the pre-hospital setting and care can minimize long-term disability and death. All right. If you take good care of your patient who's suffering from serious or multi-symptom trauma, you increase the chances of a good outcome. It's very simple. Okay. We need to be able to do a good check on our MOI to see so that our index of suspicion goes the right way. All right. Injuries occur when the body's tissues are exposed to energy levels beyond their tolerance. We got mechanical energy, kinetic energy, potential energy, chemical, thermal, barometric. All right. All these produce different types of injuries on the body, and knowing enough about how they injure us can help, and what the mechanism is, can lead you down the path of what actually might be injured. For example, a blast type injury. Common wounds from a blast, if you are close enough to the blast wave, are going to be ear problems, lung issues, okay, hollow organ injuries. So your injuries sustained by trauma patients could be from a multi-system trauma like a car crash, okay, falls, motorcycle crashes, gunshots, stabbings. Make sure that you are not just looking for what you can see. Don't just get the tunnel vision and the blinders on. Think about what you can't see too. Okay, that's a big deal on this. Blunt trauma, soft tissues, internal organs, cavities of the body, damaged and injured without breaking the skin. It becomes a penetrating trauma when something penetrates the surface of the body. Blunt trauma, object makes contact. Bang, baseball bat. Okay? Blunt force trauma. We all know that. The two most common MOIs are going to be crashes and falls. What is the, like a fall from a height, thinking about ladders, what's the most common ladder responsible for the greatest number of spinal injuries in this country? Any idea? Gallatin has arrived. What is it? Yeah, how big? A 6-foot step. But yeah, you're right on there. Yeah, because the 6-foot step ladder we get super complacent with, right? We run up and down that thing like it's the stairs in our house. And what do? We go, hey, I can stand on the top, and all of a sudden the ladder kicks sideways, you kick the other way, down you go. And you just fell from your entire body height. Okay? Motor vehicle crashes, we don't see too many really super serious ones down here in the main, the Big Threes area. Northern Lakes, you guys get them above you though. Spirit Lake Cutoff Road, areas up in there. Diagonal roads, some snot slinging wrecks up there. And then down south in Worley. All right? It used to be worse before we redid the road, but they get some nasty wrecks. Okay? Remember that you got 3 impacts. You've got the vehicle hitting the object. You've got you hitting the inside of the vehicle, and then you have your internal organs hitting your inside skeleton. Okay? So you've got all 3. You can see the brain on the right here, what happened, when it got smacked. Okay? Here's a nice seatbelt wound on this dude. Okay? He's also got some burn on him. That's that yellowish area up there around the shoulder and the arm. Okay? Contact points are often pretty obvious. Okay? You can see where the knees on the first picture are jammed into the underside of the dashboard, which causes damage to the hip because the force is transferred up the femur. You've got the head into the windshield, and then the chest into the steering wheel. Same thing on the other one, on the third picture there. Okay. I'm not going to go too much into that because that's in your book. But basically what you've got, this slide is going to detail how, you take a deep breath, you end up blunt force trauma to the chest. Well, how does it damage the lungs? It actually goes all the way down to the alveolar level where it actually pops the alveolar sacs. Okay? Causes bleeding in the lungs. Rear end crashes cause whiplash type injuries. Lateral crashes will cause a lateral whiplash. That's where you get T-boned and your body goes one way, your head stays there. Okay. Rollovers are the worst ones that we have to deal with. Most common life-threatening event is ejection or partial ejection. And for those of you, if you really want to watch something interesting, look up Arabic car crashes on YouTube. All right. Here's a pearl for you. You guys don't need to do it now. I guess if you want to do it now and you don't want to listen to me, that's fine. But Arabic car crashes. And then just start clicking on them. So paramedic pal of mine on green shift was telling me about it. I didn't believe it. I started looking up. Evidently, these guys just like to race cars through the desert. And they don't do a good job of it a lot of times. And they just yard sale these cars. And you'll see people like 30 feet in the air. All right, ejected. All right, it's crazy. Okay, so rotational crash. You've got front and lateral impacts. Your 3-point seatbelt is effective in preventing injury, but maybe not all injuries. Okay. Vehicle ped crashes. You got the vehicle pedestrian impact. Pedestrian rotates onto the hood and then rolls off onto the ground. Okay. Injury pattern is going to depend on the height of the pedestrian and the body area facing the impact. The last one I had was right in front of the library here in Post Falls. We got called for vehicle ped. When we got there, it was a guy that was trying to cross in front of the library, and he didn't make it because the car decided that they weren't going to. The entire windshield was caved in. He hit it that hard. I mean, I don't think there was probably a 6-inch spot on that windshield that didn't have a crack of broken glass in it. All right, knocked him out of his shoes. One shoe was about 30 feet up the road, the other one was down, and it was just bowling ball. Okay, she hit him probably almost a full 35 miles an hour. All right. Kid on a bike right here. Again, evaluate your mechanism, same manner as a vehicle versus pedestrian. Motorcycle crashes, not one of my favorites. Those of you that know, because I like to ride. Always undergo a cervical spine check, and then you could have a head-on, you could have an angular, they could be ejected, they could lay the bike down. That doesn't always work. There's an old school of thought from motorcyclists that say, just lay it over. It's better to ride it out on your leathers than to try and be on the bike knowing that you're going to hit something. That doesn't always work, okay? And you can see the road rash on this guy's arm here. Falls, the other big one, okay? The greater the height of the fall, the greater the potential for injury. Your internal injuries are going to be the worst problem. So you got to take into account the height, the surface that they fell onto. If somebody falls off of a 6-foot step ladder onto a concrete floor of their garage, that's a whole lot different than being outside and falling onto the ground that is super soaked with rain because it's rained for 3 days. Okay, that's almost like a sponge. Okay, what part of the body hit first? Did they land on the feet? Did they try to land on the feet and didn't land on the feet? Did they land on their head? Okay, because that's going to be where the impact zone is going to be. So a lot of times witnesses to a fall will be the ones to talk to on this, because your patient may be injured to the point where they can't tell you. Okay. For penetrating traumas, you got this guy with the knife in his chest. They can be low energy, medium, or high. Low energy is going to be something like this: basic impalement, knife, ice pick, some kind of weapon. It doesn't have to be a weapon though; it could be rebar. We ran a call not too long ago when they were building in Riverstone. Had a construction worker on a roof, wasn't tied off, fell off. They didn't have the caps on the rebar for the stem walls yet. And he got impaled by 4 pieces of rebar, 3 or 4 pieces, I don't remember what it was. Just, and he was like stuck on them when we got there. Okay, still fairly low energy. Point blank, high velocity gunshot wounds, they're going to be more significant injuries, obviously. So determine the number of penetrating injuries. Like if it's a gunshot, is there an in and an out? Or maybe just an in? Okay. A small projectile like a .22, a lot of times will come out, but it may not. If it hits the right bone the right way, it might just glance or shatter inside the body, and now you've got a single entrance wound. Okay. Hollow point bullets expand when they enter the target, and then full metal jacket cause less damage. They don't fragment, but they do carry more energy, and a lot of times we'll do it through and through. Everybody that's probably taken this class has probably seen an episode of Mythbusters. It's always interesting. You think about the ballistics gel that they shoot into to show what a round will do. That same thing happens to your body when you get shot by a round. Okay? Those of you guys that hunt know that a single bullet well placed does a massive amount of damage to the critter. Okay? You're going to be no different than that critter if you take a gunshot. The movies are not very realistic in that. Okay? A, you don't get blown back off your feet when you get shot. You usually just stand there and then drop. Okay? And B, when it happens, that cavitating force that's inside is ripping you to shreds. Okay? The relationship between your distance and severity, the injury then is going to vary. Okay? The entrance wound often bigger than the entrance wound. That's pretty much, I think, goes without saying. Most of us know that. It's important to find out, somebody, I have yet to figure out how this works, but, well, I was cleaning my gun and it went off. Well, you obviously weren't cleaning it very well because you didn't clear and check the weapon before you even started to disassemble it. What you did was you were mishandling a loaded firearm is what you were doing. Oh, and you shot yourself in the foot. Okay, well, I can do a lot more damage if it's on my leg and I shoot myself in the thigh than if it's down on the foot, because even that little amount of room, and now I've just got the bullet, I don't have all the force of the powder and the gases coming out of the barrel. So how close it is to the body matters. Okay. As far as blast injuries go, it shows, and it's most often, we see that like in a military conflict. We can also see it in industrial settings, a storage tank explodes, something like that. Your primary blast injury is the blast itself and the damage that it does. Okay, the damage is usually caused by a pressure wave, although you can get burns from it, type of explosion that it is based on that. How close you are is going to determine how dead you get. Okay, your proximity matters. Okay, if you look in your books, not that you have them open, but you'll see that there are rings. Okay, where you've got the blast happens, and then you've got a ring, and then you've got another ring, and you've got another ring. Okay, where you are in relationship to the blast is going to matter, and it's also going to tell you a lot about possible injury patterns. Okay, so your primary injury, what you've got is you've got the blast wave itself. That's bad. Secondary blast injury, that's the gravel and the rocks and the ball bearings and the nails that we put into the pressure cooker to make it into little missiles that get blasted out in all directions. Okay. A common practice that Hezbollah used to use back in the Holy Land when they were doing a lot of bombings back there was they would also include a bunch of rat poison in it, because the rat poison is an anticoagulant. That's how it kills the animal. All right, they eat the poison, the blood can't clot, causes internal bleeding on the rat, and it dies. Well, if you put that in a bomb and you mix it around with everything, you might get hit by only 3 or 4 pieces of shrapnel, but the wounds are going to continue to bleed. Okay, rat poison's going to anticoagulate you. Okay, the tertiary injury, that's where you're blown up. I'm flying through the air, and then I hit into a wall. Okay, that's tertiary blast injury. And then the quaternaries are injuries such as burns, crush injuries, inhalation of the gases, and the like. Okay. We got all that. Okay. Tissues that are at risk from a blast. Okay. Organs that contain air are the most susceptible. Those are the lungs. Blast lung, sometimes called the butterfly or butterfly lung. See that a lot. If you look up butterfly lung, what you're going to get on a Google search, if you do an images search, you will get x-rays of lungs that literally look like they're opened up like the wings of a butterfly. And most of them will come from like Israel, Pakistan, places like that where they bomb people and they blow them up on a regular basis. Okay. Pneumos, common injuries, might have to do a decompression, might have to have a medic on them. It's not something we're probably going to have to hopefully deal with too much, but we do have bombs up here. North Idaho, actually, for a while, was the largest center for domestic terrorism in the United States. Okay, as far as multi-symptom trauma, or multi-system, excuse me. If you've got trauma that involves your respiratory system and your circulatory system and, all right, your best defense is the wheels on your ambulance, because you're going to be behind from the minute that you start. Okay? These patients are super, super sick, and there's a good chance that they're going to try to die on you the minute that you walk up to them. All right? It's very high morbidity and high mortality rate for multi-system traumas. Okay? Your golden principles: make sure that you're safe, seen safe, determine the need for what you're going to need as far as additional help. You probably will. Get a good look at your MOI, manage your life threats, check your airway. Okay? Do your shock therapy. A couple large bore IVs. 18s or better. All right? It's one of those go big or go home kind of times. Rapidly do your spinal immobilization as indicated. Try to get a sample history. If they're conscious, you may not be able to. Okay? If you're in an outlying area and you don't have a medic around, which isn't most of us, but if you do, get one coming. All right? You're going to need the help. Helicopters as well. Okay? If you're not in the local area, launch the bird. Life Flight is budgeted for a 60% cancellation rate. That means they plan on the fact that 60% of the time that they're launched off the ground, they're going to get turned around midair and go back to the hangar. Okay? So do not be afraid to launch them and then call them off if you don't need them. Their system is built on that. They get it. Okay? Find out what they've got. Try to find their illnesses, their injuries right off the bat. Assess, triage, treat, and transport them, and take them to the most appropriate facility. It's very rare that we go across the border. At least in Coeur d'Alene, we don't generally transport out of the city. We go straight to Kootenai. And 90%, 95% of the patients in the county go straight to Kootenai. But there are those patients, okay, that we can, when we have the option to do this, if they will be best served over in Spokane, maybe that's where we need to look at taking them. Make a phone call if you really think that that's what they need. Don't be afraid to do that. Okay, injuries to your head. Problem is you can't really see what's going on in the brain. You can only see the effects of what the brain is or is not doing. Okay? Bleeding and swelling inside the skull is going to be considered life-threatening. The brain is a cranial vault. All right? The skull, it's got one opening in it, and that's the foramen magnum at the bottom. Okay? Where the brain stem comes out. Brain starts to swell, what's it going to do? It's got only one place to go. So it's going to start shoving itself and pushing the brain stem down through the hole in the base of the skull. Okay? That's why a lot of times when somebody has swelling of the brain, they will take a part of the cranium off. All right? And just pull part of the skull cap off to alleviate the pressure. Okay? Neck and throat. You're dealing with an airway issue. Remember your decap BTLS. Make sure anytime you have an open neck wound, you use an occlusive dressing. All right. So what do we have for occlusive dressings? We've got the little Vaseline gauze. All right. Easiest way to do that. Be very careful when you do it. Use your gloves. Open it up. Peel the wrapping back from the gauze. Take the gauze out. Toss that in the red bag can that's on the door of your ambulance, and then take the foil and slap it on the wound. Sterile side in. That's going to be your best occlusive dressing. Because that Vaseline gauze, you can't tape it down. You can't do much with it. Okay? I mean, it's a good idea in theory, not such a good idea in practice. Okay? Use the actual wrapper for your occlusive dressing. Blunt trauma to the chest can bust ribs, maybe fracture your sternum. It's hard to break a sternum. Okay? It can be done, but it's hard. Okay? The large vessels, the pulmonary artery, the aorta, those can be torn or damaged with significant blunt force trauma, all right, or any of the branches around them. So you have to be thinking about that. You can develop a pneumo, all right, standard pneumo or a tension pneumo, okay, or a hemopneumo, okay. Every 5 minutes you need to reassess these folks, and you need to have a medic with you because we can't decompress at the advanced level, all right, and they might need that. All right. It's also pretty cool to watch them do it. Okay, needle decompression is pretty bad. Pretty awesome. Inside your abdomen, solid organs can get torn. Okay, liver, spleen, those kinds of things. And if they do, they bleed profusely. Okay, you can rupture a spleen and you can bleed out in a matter of minutes. Livers do not deal well with open bleeding. Okay, they just continue to bleed and to bleed and to bleed. You lacerate that guy and you're in real trouble. Okay? Your hollow organs can rupture, and it says leak toxic chemicals. You're basically going to get stomach acid where you don't need it. Okay? The lining of the stomach is designed to deal with stomach acid. The rest of your inside of your peritoneal cavity is not designed to deal with stomach acid. Okay? And it can cause real problems. Healthy young adults can compensate better than older adults. You guys like Max here, who's in his early 20s, the same injury to him and me, he's going to be able to deal with it a whole lot better. I got 30 years on it. Okay? Doesn't mean I can't deal with it, but he definitely can deal with it better. All right? His body's still able to compensate better. But still, if we have the same type of injury, I get stabbed in the chest, he gets stabbed in the chest, maintain a high index of suspicion that even if he is compensating, he might decompensate. He might lose that ability. Don't just say, he's got this, all right? Because he could all of a sudden go from talking and carrying on with you and having a good conversation in the back of the ambulance to unconscious. Okay. I love it. Okay, your trauma lethal triad. Factors that interfere with blood clotting will cause more blood loss. Okay. If you look at this, you've got hypothermia, you've got acidosis, and you've got coagulopathy. All right. Some of the things that we do to compensate and to help our trauma patients can actually cause problems. Okay. For example, we worry about patient going into shock. So what do? At the BLS level, well, we elevate their feet, we keep them warm, we cover them with a blanket, right? Okay. At the advanced level, what do? Well, now we can start fluids. That's awesome, good times. I'm going to get my fluids started. I'm going to run it wide open. I'm going to start another IV. I'm going to run it wide open. Okay. How warm is the back of your ambulance? 70 degrees, 80 degrees, whatever you got the air conditioner set on. How warm is a human being? 90 plus degrees, right? If you're not using warmed IV fluids that are specifically warmed up to a certain degree, you're going to be pumping them full of cold liquid as fast as you can flow it into them because you're trying to save their life. But what are you going to do? You're going to throw them into hypothermia. Okay? You've just added one leg of the triangle or one side of the triangle. Okay? You've got to control the bleeding. Limit your scene time. Shoot for less than 10 minutes. We actually do a pretty good job about that in this county. I didn't think it was as good as it was. But if you go back and like on some of these critical calls, sit in with the medics on their what is the name of the meeting? What do you do with Chun? Yeah, sit in on their TCR. Okay? Dr. Chun, when he goes over it, talks about the times. He says, okay, you were here, you were here, you were here. But a lot of times, we're on scene not that long. 5, maybe 10 minutes tops. Unless we've got something difficult or something really strange, we don't get into these 15, 20-minute scene times. We're still usually a pretty quick turnaround. Okay? If they're critical, get in, scoop them up, get them in the back of the ambulance, and start transport. Okay? Be very concerned about a dangerous mechanism, any kind of serious mechanism, any kind of decreased level of consciousness and threats to airway, breathing, or circulation. Okay? That's the same as it was in your BLS class. Okay? How do we get them there? Well, you can fly them. Got a nice helicopter here. All right. Be familiar with what it takes for air medical transport. For us, heading south to Worley. Okay. If it sounds bad, I know a lot of medics, they will just say, you know what, launch the bird and get them going. Because they got to come from Sandpoint anyway, so you might as well send them. And it's not uncommon, while we're driving around the lake trying to get south to the Harrison area, we'll get there and the helicopter's lifting off. Okay. We got a nice drive out of it at least. Okay. Distance to trauma centers greater than 20, 25 miles, be a good criteria. Patient needs ALS level care and stabilizing at that level. Traffic used to not be an issue, but at 4 o'clock in the afternoon, it can be a problem trying to get to the hospital, can it not? It's absolutely a pain in the neck sometimes. I can't even imagine what this summer is going to be like once we put all the tourists in town and they're all trying to figure out, oh, this is Ironwood, this is a nice, easy way to get across, and we're never going to get there. We're going to have to run lights and sirens from the minute we hit Northwest Boulevard or 90 or 95 just to get to the hospital sometimes. And anytime we have multiple casualties, we might need to send the most critical by air and we'll send the rest by ground. We do that for the most part anyway already. All right. Know what the criteria are if somebody is critical enough that you might have to bypass your local hospital and send them to a bigger one. Okay. Kootenai can take level 2 traumas. Yeah. Kootenai's a level 2 trauma center. They might need a level 1. Okay. And it may not be, you can make the call on scene, but it may be that they're best served by sending them directly to a level 1 as opposed to a level 2 to give them the chance to transfer them to a level 1. Because that just took another half hour out of it. Okay? Or 45 minutes. Okay. We all know that there's adult trauma centers and there's pediatric trauma centers. Spokane is the closest pediatric center that we have. All right. And a lot of these slides, think about this, a lot of these are for a city like Spokane. Well, you got 4 or 5 different hospitals that you got to deal with. All right. We have A. And ours doesn't do a bad job for what we have. Okay. They really don't. They try. And they steadily keep ticking up and doing more things. If you told me 10 years ago we were going to have a NICU and a specialized, I'd have laughed at you. I said, there's no way. Not our little hospital. Yeah, we got one now. Okay. Oops. Was that it? That couldn't have been it. That was it? Wow. You guys want to do another one? All right. Questions. And I'll wait a couple minutes for you guys on the other end. I know I kind of went through that. There's not much to it. Okay. Most of that is BLS stuff. It's just upgraded 1 notch. All right. For the speed that I did go through it, that preclude you from getting back into your books and continuously taking another look at it because you don't want to go back into your test and miss dumb stuff that you already knew. Remember airway first. Remember breathing second. Multi-system trauma kills people. And don't be afraid of gynecology. It's actually worth learning about. All right. Sooner or later, you're going to get those calls. All right. All right.
All the guys are saying thank you.
Appreciate it. Thanks, guys. Ryan, good to see you again. Sort of.
Thanks, Ruber. Matt Church says nice job.
He said neat. Matt doesn't say nice. It's always neat. All right.